Now we'll move from frontline therapy to relapse therapy, how to best manage patients with relapsed mantle cell lymphoma. And I'm going to argue for ibrutinib-based therapy alone or in combination. These are my disclosures. Bruton's tyrosine kinase inhibitors, or BTK inhibitors, have really revolutionized the treatment for mantle cell lymphoma. There are currently 3 approved BTK inhibitors for relapsed refractory mantle cell lymphoma, with the first approval coming in 2013 with the approval of ibrutinib. Since then, the second generation inhibitor, acalabrutinib, has been approved, and most recently, Xanabrutinib. These agents have very high overall response rates in relapsed mantle cell lymphoma. However, patients will inevitably relapse, making combination therapies of interest to both increase the depth and duration of response. However, it should be noted that currently there are no FDA-approved combination therapies. As I mentioned, ibrutinib was the first approved oral BTK inhibitor when it showed a 70% overall response rate in relapsed refractory mantle cell lymphoma with a median progression-free survival of a little over a year. This really provided a fantastic option for these patients who didn't have a lot of effective therapies. Further follow-up of 3 studies, pooled analysis of these 3 single-agent studies, had shown that ibrutinib is really best used when it's used as the first line at relapse. In these 3 studies, it showed that when you use ibrutinib as the first treatment after somebody relapses, the median progression-free survival is over 2 years, and the median overall survival is not reached. For those patients who achieve a complete remission, the median duration of response is over 4.5 years. And this has led to the thought that this really should be your first choice when patients first present with relapse. It's important to note that TP53 mantle cell lymphoma is a hard-to-treat mantle cell lymphoma, and these patients have a poor prognosis overall, regardless of their therapy that they're treated with. When you look at ibrutinib's single-agent response in TP53 mantle cell lymphoma patients, over half the patients will respond, but their median progression-free survival is really short, and these are patients who need to be prioritized for therapies beyond single-agent BTK. Not only are responses better for patients when they receive ibrutinib as their first line of therapy, but their toxicity is less and they tolerate the agent better. So the pooled analysis of these 3 studies showed that patients had less toxicity when ibrutinib was used as first relapse. And not only did patients have less toxicity, but as patients were on treatment over time, the number of reported adverse events decreased. So if patients were able to be on the therapy for a year, their toxicity was less after that first year of treatment. Now, it's probably intuitive to think that any agent that you use at relapse is going to be more responsive when you use it later in line of therapy. However, this was a retrospective study that looked at using a number of different agents at first relapse and showed that ibrutinib actually showed a survival benefit over the other agents, including chemotherapy and other novel therapies, when it was chosen as the first therapy to be used at relapse, suggesting that in the majority of patients, that BTK inhibitors are the best approach at initial relapse. Acalabrutinib is a second-generation BTK inhibitor that has less off-target effects, so it's more specific to the BTK and less kinase inhibitor activity of the other kinases. This leads one to believe that the therapy should have less off-target effects and therefore be better tolerated. A phase 2 study of acalabrutinib showed overall responses similar to that which is what's seen with ibrutinib. Complete remissions were double of that which is seen with ibrutinib, but given the difference in response assessment by CT versus PET, this could explain that difference. When you look at the median progression-free survival and median overall survival, it was similar to that which is seen with ibrutinib, with a median PFS of 20 months and a median overall survival of not reached. Perhaps where we'll see the biggest difference between these agents is in toxicities. Like ibrutinib, toxicity with acalabrutinib did improve over time. Headache was more frequently seen with acalabrutinib. However, events such as bleeding were less commonly seen with acalabrutinib, and atrial fibrillation in this study was not seen, although it's been reported in other studies with acalabrutinib. Randomized trials are ongoing between the two agents, but it may be that the toxicity profiles is where they vary the most. Finally, Xanabrutinib was a third BTK inhibitor approved just a little over 6 months ago. This was based on 2 studies showing similar overall response rates. Again, a striking difference in complete response rates, although one was CT criteria and one was PET criteria. And if you look at the median progression-free survival, they were very similar to each other and similar to what's reported with the other BTK inhibitors. Again, this is a more selective BTK inhibitor. And a recent randomized study in Waldenstrom's actually showed a significantly less incidence of both atrial fibrillation and bleeding with Xanabrutinib as opposed to ibrutinib, but a higher rate of neutropenia with Xanabrutinib opposed to ibrutinib. So while these all 3 probably have similar efficacy as far as response rates and duration of response, it may be that their differences lie in the toxicity, and that's where you want to look at the preference is based on an individual patient's risk factors. We know that progression after ibrutinib typically happens fastly, and overall survival after progression on ibrutinib is poor, with several different studies showing a median overall survival of less than 6 months once patients progress on ibrutinib, making there a high need for these responses to last longer. That brought about a lot of interest in trying to figure out both how to make that happen and why that happens. So this was a small retrospective study out of MD Anderson, but did show a number of these patients progressing on ibrutinib require TP53 mutations, which may in part explain their aggressive behavior. Adding on to BTK inhibitors has been of high interest to increase duration of response and depth of response. A phase 2 study looking at the addition of rituximab, however, showed that while in patients with low-risk disease by Ki-67, there were good outcomes, there really wasn't much benefit in those patients who had higher risk disease with Ki-67 above 30%. Probably the combination of highest interest is the ibrutinib and venetoclax combination. Venetoclax is a BCL2 inhibitor with phase 1 data showing similar response and PFS as ibrutinib. Venetoclax, however, is not approved in mantle cell lymphoma. So this trial combining the two showed similar overall response as single agent. However, everybody in initial reporting achieved a complete response, and that included a 50% complete remission in those patients with TP53 disease. Further follow-up showed an overall response rate of 71% with 62% complete remission and high rates of MRD negativity. The therapy was in general well tolerated. There was a higher incidence of diarrhea and cytopenias which were well controlled and did not lead to therapy discontinuation. Median progression-free survival was favorable with a median PFS of 29 months and a median overall survival of 32 months. One of the interesting things that came out of this trial was that there were 5 patients who went off treatment after achieving an MRD negative state instead of continue on therapy indefinitely, which is how both of these agents are otherwise used. And 4 of those patients remained in an MRD negative remission at follow-up of 6, 13, 17, and 18 months. This is very early, but it does suggest that there may be a population of patients where you're able to stop therapy in these diseases, which would be of high interest both from the standpoint of toxicity and cost. A second study is currently ongoing, which shows of this combination, showing similar overall response rates, but a lower complete remission. And there is a randomized trial ongoing looking at ibrutinib versus ibrutinib plus venetoclax, which will really help us to determine if the long-term outcomes of this combination is more favorable to BTK alone. Ibrutinib, lenalidomide, and rituximab has also been evaluated in the relapse setting with high overall response rates, but similar to that with single agent, but a higher complete remission, although looking at the median progression-free survival, it's similar to that seen with single agent therapies. Due to toxicity, this might not be a combination of interest in everyone, but if you look at those patients with TP53 mutations, the overall response rate in these patients was 73% with a CR of 64%, including 50% MRD negative. So it may be that in those high-risk patients, this combination might be an effective effective option. As I mentioned, TP53 predicts poor overall survival with a median overall survival after diagnosis of less than 2 years. These are patients who are desperately in need of better therapies, both upfront and at relapse. And lastly, I won't go into this much as it's a discussion of the next topic, but the CAR T is a favorable option and has shown very high overall response rate with complete remission rate. However, it's important to note that all the patients treated on this trial had progressed on BTK therapies or had at least been exposed to BTK therapies, and this wasn't without toxicity. So this may be a choice in those patients with high-risk disease such as blastoid or TP53, but in the large majority of patients, they should be exposed to BTK inhibitors first. In summary, I would say that BTK inhibitors are the preferred second line of therapy. Combinations are of high interest due to the ability to potentially both increase the depth and the duration of response. In general, the toxicities are acceptable and tend to improve over time as patients are on therapy. BTK inhibitors can be used as a bridge to CAR T or allogeneic transplant with very good responses in these forms of therapy once patients have started to progress on BTK inhibitors. High-risk populations, such as those with TP53, may benefit from a more aggressive approach, and this is maybe a population of patients where we want to look at other therapies outside of single-agent BTK inhibitors.